welcome to Hence the Future podcast. I'm Mattimore Cronin,
And I'm Justin Clark.
and today we're discussing the future of healthcare. With us today is special guest John Gautsch. John is a health tech entrepreneur and founder of Preferral, a software company that helps streamline care coordination between physicians and specialists in America's oftentimes disjointed healthcare system. John, it's a pleasure to have you on the podcast.
Yeah, thanks for having me. I'm excited to be with you guys.
Awesome. So I thought before we talk about the specific problems and solutions for America's modern 2018 healthcare system, we can put it in the larger context of history and how it's been to be a human, sick or healthy, throughout the course of what we've experienced up until now. And I was pretty interested looking into this because it hasn't changed all that much up until the last 80 or 100 years. You know, in Neolithic times, we had a lifespan of about 33 years old. And that actually dropped during all the Greek and Roman wars and all of that, and really stayed around that level up until the 1900s. Then it went a little bit higher up to, the later 30s, early 40s, and up even until World War II, when President Truman actually called for national universal health care in America. It was only 48, the average life expectancy for a male. So now we are at 72 years old is the lifespan as of 2014, and it's predicted that the first person ever to live to 150 years old has now already been born. So if you look at the chart of lifespan, it really has skyrocketed just in the last, several decades. So I think it would be good just to note that things are pretty good now in the context of history, but what comes with a longer lifespan is a longer period in your life in which you're sick. So I think this is something that we've not really had to deal with where, 50 years you're a more feeble type of person, which is why lots of healthcare companies are really focusing on the health span and how can we make someone who's 100 years old feel like people do now when they're 60 years old. So I think unless you guys have anything else to add to the context, I think it'd be good to talk now about the specific problems that America's facing today.
I had a couple things that might be interesting to think about. So the one thing that I noticed about the health or the lifespan of people over history is it seems like, at least the way I understand it, is it's so low because the infant mortality rate was so high. So if you look at the average lifespan, and almost half of all infants die at birth, then the overall lifespan is, dropped, the average lifespan across populations. So, we have these huge innovations like, hey, maybe we should sterilize our hands before, taking
open heart
before
surgery.
yeah, before birth or before any sort of surgery. There's a lot of little scientific discoveries along the way that made healthcare better. So, hundreds of years ago, we were basically trying to use alchemy and a whole bunch of other crazy things that seemed like they might work. And maybe there was some truth behind some stuff, like some herbal medicines, and we've seen that there's at least some sort of effect in some herbal medicines, but for the vast majority of things that were practiced in the past, I mean, it's so archaic to think about. But, like you were saying, over the past 50 to 100 years, we've had some really big innovations. So we see healthcare quality rising with technological innovation.
Yeah,
and, that'll just keep going.
One interesting point of that, how healthcare used to be kind of like alchemy, is that when Abraham Lincoln was shot, what they brought to his side immediately was mummy paste, which was real, genuine Egyptian mummy paste that they would put in his open gunshot wound, because it was thought to have healing powers, because how else would mummies be so well preserved unless it had some healing powers? So it's interesting how far it's come, and it's easy to pat ourselves on the back and talk about how much great progress we've had, but it's also notable that it's the single biggest issue in the American political system right now. So people clearly are not happy with the status quo of what's going on with healthcare. So I'd like to ask John, from your perspective, given that we've been using the scientific method and making some great leaps and bounds in progress over the last several decades, why are people so unhappy with the status quo in healthcare?
Well, so I think it's worthwhile to separate the issue of healthcare, to distinguish the sort of art and science and practice of medicine, as well as from the sort of delivery of healthcare, and then also further separate it from the sort of political campaigning chip of healthcare, from the actual issue of are people receiving the care they need. So all of those things can sort of be separated from one another. But just to rewind just a little bit about the point of increasing life expectancy and sort of the effect that has on the healthcare system. It's not just that people are living longer. The sort of secondary effect of that is people are living beyond their working years.
Right.
So if your life expectancy is 35, you're working till the day you die. Even true if it's 55, but if you're living till you're 90, that's 15, 20 years. You're not working. You're basically just living out on resources that need to have been accumulated up to that point. So all of those things sort of add to the sort of complexity of the healthcare issue that we face today. But in terms of sort of advances that have made, those are squarely in the realm of the art and the science and the practice of medicine. And as a disclaimer, I'm not a physician, so I'm absolutely not an expert on these matters. But talking back to Abraham Lincoln's time, talking about the bullet and the sort of desire to get that out of his body. He was killed in the mid 1800s, 1865. Well, anesthesia was only invented not too long before that. So prior to the invention of anesthesia and the sort of wide adoption of anesthesia in medical procedures, every medical procedure had to be about 10, 15 seconds, or as long as you could hold a patient down.
You just get a couple swigs of whiskey and bite on a piece of
hold
wood.
Them down and try and rip it out for 10 or 15 seconds, because that's all you got. Anesthesia was a breakthrough innovation in the practice of medicine, and was pretty quickly adopted by the rest of the world. But there have been other innovations that have come to fore through the scientific method that have been less quick to be adopted. And so there are plenty of examples that sort of plague the healthcare system that we know what's the best practice that we don't do. So the healthcare system does a radically bad job of adopting good ideas.
Well, so what's an example of that?
So a good example of that is the World Health Organization recommends the sort of average baseline C-section rate should be between 10 and 15% of births. But in the U.S., it has actually doubled over the last sort of generation from 2000 to 2015. C-section rate went from 12% of births to 21% of births. And, has all that much changed in birthing over the last 15 years? Why the change?
Is that because
actually, if you
women don't want to go through the process of giving birth, or what would be the
reason? No,
in
fact, many C-sections start with attempted natural birth, but often then get moved to C-section either for fear of the mother's life, fear of the infant's life, or often failure to progress, it's called. So the baby's just not coming along quick enough. And the sort of interesting thing about this issue in particular is that it's extremely idiosyncratic in terms of when C-sections are pushed for. So the rate of C-section in the U.S. as of 2015 is 21% of births. But if you look at the data across the spectrum, you've got idiosyncratic rates between hospitals, so where you're going to give birth. And some hospitals have rates as low as 7%, and some have rates as high as 70%. So
I've always thought like it would be super helpful to have a guide through your healthcare experience, because like for me, I injured my hand, so I went to the hospital and I got an infection while I was there. And so I had all of these different doctors and specialists coming to see me, and here's the infectious disease specialist, and here's the ear, nose, and throat specialist. And for me, it was just like I was in this dazed whirl of people coming in to see me and leaving, and then I would get bills, and I didn't remember, like, did I actually see this guy, and why does he cost so much, and does my insurance cover this? And it just seems like a whirlwind of confusion and misdirection and obfuscation, And so I agree. It's not
Yeah.
like the scientific methods problem. It's more a problem with the delivery and the system itself. So how did we get to this place where it's so far from the normal supply and demand economic model of the rest of our society?
Think that's best approached by sort of acknowledging some sort of broad general themes that exist and have sort of created a system of counter incentives or incentives against sort of the stakeholder parties. So it's almost impossible to think about healthcare delivery in the U.S. without giving almost primary consideration to the payers and how healthcare is paid for. And so right now in the U.S., of course, we've got private payers, we've got public payers, we've got private insurers, Blue Cross, Aetna, Cigna, Humana, et cetera, and you've got the public payers. So the Center for Medicaid Services, Medicare, of course, for the elderly, and then Medicaid for the sort of lower income population who otherwise wouldn't have access to private insurance. This actually brings in the question of, okay, well, what's the future of single payer? These sort of very, very hot button terms that are often thrown about, but sort of insurance covered healthcare. Where did that even come from? And it came from the early 19th century or the early 20th century. So, we have insurance. Typically, it's employer provided. So employer purchases a group policy from the insurance company. But that wasn't actually a thing until World War II. There were policies that you could personally purchase to cover work injuries, but often those were basically not to cover the cost of your healthcare, but just to reimburse your lost income. So people would purchase those, do dangerous jobs and that kind of thing. And that was kind of the state of affairs. Then during World War II, to sort of control wartime economy, they basically capped wages. And as a way to incentivize employees to come work for your company, if you weren't allowed to offer them more money, you offered them fringe benefits. And that's when employer-sponsored healthcare came into the scene, employer-sponsored insurance coverage. So they could offer that as compensation, and it wasn't seen by the government as wages, and so it flew under the radar. And now it's also a way to sort of compensate employees' pre-tax dollars as well. But the sort of unanticipated consequences and effects start creeping in. So your ability to change jobs is hampered by the fear of losing healthcare coverage, which is bad for consumers generally and broadly speaking. And then sort of a heuristic that I think is good to sort of analyze these things through is that power tends to concentrate upon itself.
Right.
So if you have power, you're going to use your advantage to basically get more advantage. And we're seeing some of the later stages of that in the insurance industry right now.
Yeah, it seems kind of similar to me to our education system, where it's not being subject to the normal laws of supply and demand and private sector and giving the best solution at the most efficient price to the person who needs it the most, where instead it's almost like, because we have this system where you don't know exactly what you're paying for and you're just giving them some amount, which is your copay, and you're subsidizing the other people who might have greater healthcare costs than you do, and then that leads to more healthy people dropping off because they don't want to pay these higher copay costs, and then it just sort of doubles up onto itself. So I'm wondering, like, what would a better model be? I mean, I know there's been a lot of talk about the single payer, and that is something that Truman proposed back then, and I've heard other people talk about how, well, single payer works in some countries like Denmark and Norway, but those are much smaller countries. When you look at a country as big as America, to have one single payer system is very difficult to make that work for everyone. So I've heard someone else propose, okay, well, maybe we have a single payer, like a government option, so anyone who wants can get this option, or you can also pay a bit more to get private healthcare. And that's something like, for instance, in Singapore and some other countries have that option. From your vantage point, what do you think would make the most sense for our country?
Yeah, so the sort of these heuristics that I think are useful in sort of analyzing the state of affairs or where we could go and what would be useful is that of course competition is generally good for consumers, and sort of competition implies the idea of being able to shop for your healthcare, and so that sounds counter to a single payer system, except that sort of shelving single payer idea for just a second, because I've got definitely a lot of thoughts on that.
Yeah.
That's just the very beginning of the question, where there are 10,000 things to sort of answer first. But in the U.S. today, still sort of considering the state of affairs as it is today, it seems like, well, competition exists, good for consumers, except that our ability to shop for healthcare is totally non-existent.
Right.
So if you want to call up a doctor's office and ask how much is it going to cost to do X, they pretty much can't tell you because they don't know. The reason they don't know is because rates that they're reimbursed at with each different insurance company are separate. A provider negotiates their reimbursement rates with insurance companies individually. It's not a set number.
That's so crazy.
Not only that, but the rates that they've negotiated are proprietary and are not allowed to be shared between physicians in order to give the insurance more negotiation leverage. Because if Dr. Sam got 50% or 150% of Medicare, and Dr. Smith over here is going to want that same deal. And insurance, of course, from the insurance companies. But sort of progressing, as I said, it's kind of the late stages of competition. There's been sort of regulatory or inertia-based sort of capture that has totally eliminated the ability for new entrants into the insurance market. You basically can't start an insurance company today. There was a sort of long history of fly-by-the-night insurance companies that cropped up, took everybody's money, and then ditched town. And that sort of spoiled everybody on the idea of being able to compete in that sector. So, regulations put into place that make it very, very difficult to do that, and thus give a sort of oligopoly to the existing insurance companies. And now they're starting to do attempts to consolidate, of course. So like in 2015, the two big insurance mergers were announced. Both have been struck down by the DOJ ultimately, but Aetna and Humana attempted to merge, Anthem and Cigna attempted to merge. So you say single payer, it's like, well, is it single payer in the private market or the public market? Is it single payer via monopoly or via publicly funded healthcare? But then even considering the idea of single payer, a lot of the criticism often comes in the form of, wait times are going to go through the roof. Look at the NHS in the UK. It takes them a year just for routine procedures, all these kind of things. But even that is looking at just sort of one way that it could be, and a way that's actually more analogous to the VA rather than to CMS in the US. So the NHS in the UK, it's not just that it's government-funded healthcare by a single payer. It's actually government-funded, and then the physicians are employed by the system as well. Whereas if a public option or a single payer option in the U.S. were to materialize today, it would pretty much just be on the payer side, almost certainly. And so then the providers would still be basically contracting with the payer, but not actually employed by them. And that's an important distinction. So people say, well, the VA is all this, all these problems and stuff like that. I actually think the analogy to education is a very, very interesting one, because CMS, I feel, has demonstrably done a good job of showing that they are different in their ability to operate efficiently than the VA. So a very sort of counter analogy to be drawn is actually the charter schools. So we've got public education, right? But then we've actually got public funds going towards charter schools. And also just sort of to fold it in here, a lot of times when people are debating the issue of single payer, they're kind of talking past each other because there's fundamental disagreement on what the goal of single payer should be. Is it about care access or is it about care quality?
Right. I feel like
things that can be optimized for. But just to sort of wrap up the analogy on the charter schools, a lot of times people feel charter schools are for, like, the point of a charter school is school choice. And that's a benefit, certainly, and a selling point, absolutely. But a lot of times also the point of charter schools are an opportunity to basically run experiments to find better ways to do certain things. So if a charter school does a certain thing a certain way and it works really, really well, let's do that for the system broadly speaking. And Medicare has sort of done that with Medicare Advantage plans, which are basically privately managed factions of Medicare. So Medicare says, we've got all this money. We recognize we could be administered more efficiently. Hey, private companies, if you want to come in, we're just going to give you the cash. You administer it. And if you do so profitably, the cream is yours to keep. And then people get bent out of shape when they do so, and then they say, okay, well, now we're only going to give you this much. It's like, well, okay, maybe that's Medicare being shrewd, or maybe that's actually just them doing a good job of making themselves more efficient by running essentially experiments.
I agree. I mean, it definitely matters what you optimize for, and I think the analogy is good on a number of levels with the education system. For instance, with the education system, when people talk about universal college, like paying for everyone in America's college degree, most old school thinkers will scoff at that and say, how are we going to pay for that much? And they think about it in the old brick and mortar, like, look at all those colleges and the dining hall. And it's like, no, 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 no. You're thinking about it in like the 1900s way of thinking about it. If you instead think of it in the digital world, where you can record every amazing professor, compile it into some free online portal where anyone can go through your choose your own path of education and learning from the best of the best. That would get you not 100% of the way there for education. You still need your social education. You still need to, have these life experiences, but maybe it can get you 80% of the way there. And I think that with healthcare, it's the same sort of thing where if we, I was listening to this one BBC podcast where they were talking about this company that basically creates these healthcare pods. And so imagine you go to like a CVS or a Rite Aid or whatever, and they have this pod, and you go in there and you video conference with a healthcare professional, and the healthcare professional listens to your symptoms, and then it can say, okay, now take this thermometer that's right here, put it on your chest. Okay, I've got your readings. Okay, now put on this. And they can basically do 90% of what's done in a doctor's office completely remotely. And of course, there's also these TeleMed where, I know some people like in San Francisco, for instance, who they pay like $50 a month to use some app that basically they can text with any healthcare professional that they need in real time. You can also book appointments through there. And so I just wonder if our thinking about how to give everyone universal healthcare is too anchored in the way that things used to be, and it's not creative minded enough in the way that things could be in the future.
Oh, absolutely. Yeah, I couldn't agree more. I mean, there's so much low hanging fruit opportunity to basically decrease the cost of the system and thus make universal coverage or universal providing of access to healthcare much, much more viable. And there's low-hanging fruit all over the place. So the number one cause of death in the U.S. right now is heart disease by a long shot. And heart disease is primarily caused by hypertension. Again, not a doctor, so I'm going to get the nuance of how to phrase that properly, possibly slightly off. But hypertension is one of the largest, basically, causes of death in the U.S. And it's massively underdiagnosed. I think it's like 1 in 3 people in the U.S. actually have hypertension, and like less than half of it is diagnosed. And treatment of hypertension costs pennies. The drugs are cheap, but it's just undiagnosed. So if we did a better job of just managing that one, if we increase coverage, do that, then okay, we've done a good job of cutting the death rate quite a bit. I mean,
yeah, and the number 3 cause of death is doctor error in the U.S.
Oh yeah.
So if you have, it's similar to like almost, the transportation stuff where a self-driving car doesn't have to have a 0% death rate. It just has to have a better death rate than humans do. And so that's real. And the other thing that's interesting is that human doctors haven't had to go up against any possible challenger up until now. So I actually think that with these, sort of AI doctors as an alternative, that might get regular doctors to up their game a little bit. And they might come up with new startups where you take the best, like a cybernetic collective of machines and human doctors, and put it together in a way that's efficient and effective and has a much higher success rate.
Yeah, and I think there's a lot of low-hanging fruit, sort of in the immediate term, to just massively leverage the reach of individual physicians. There's a company that's been very, very interesting to me. Whenever people say telemedicine, the immediate thing that comes to mind is Skype with your doctor. But I think there are sort of better opportunities. So there's a company called Lemonade Health, and basically what they do is if you've got one of 5 very common ailments, you basically hop on Lemonade Health, answer basically a questionnaire, and then wait a couple hours. It gets reviewed by a physician, and then your prescription is waiting for you at the pharmacy closest to you. There's no need to spend the day going into the office, doing all this kind of stuff. No need to wrap up insurance into this. You just pay $20, and a single physician can review 1,500 of these things a day.
Wow.
That's covering a lot of the common ailments, and that's great for consumers. So that's an immediate low-hanging fruit opportunity, enabled by technology, but that rethinks the sort of delivery of healthcare. And actually, you sort of mentioned transportation. I think there's another analogy to be drawn about how we think about the goal of single payer or universal healthcare coverage, really more broadly speaking in the U.S. We tend to want to think about it as necessarily being some sort of profitable or at least break even affair without thinking of the impact on the economy broadly speaking. So we do the same thing with public transportation. We sort of mentally think, oh, well, we're just throwing all this money in this public transportation. So the argument against it, without realizing that, okay, well, it doesn't need to be break even on the balance sheet of itself as a unit, but everybody gets to work that way. That's great for the economy. This lifts everything up. The value is beyond just its
yeah, it's kind of like how we used to think of the news as something that was just a nice public service, and now that it's all about profits, we're living in this crazy fake news dystopia because everyone's trying to get as much money for their clicks, and news has to be profitable.
Yeah.
I think that that's actually a good segue into the priorities of America with our budget. And I was just looking at a couple pie charts before our call, where I was looking at the federal budget of America versus the UK, because I've seen that the UK, I mean, first of all, the UK is very similar to America as far as where we come, our roots and everything. And it's a good proxy to how America could be, although, on a much smaller scale. And they have been ranked as having some of the best healthcare in the world. So the UK spends about almost 20% of their budget on healthcare. And they only spend about, 5% on their military. Whereas the US spends 57% on their military. And then we only spend about 5% on our healthcare. So it doesn't take a brain scientist to see that our priorities are just completely different. And I don't think that it's so inexplicable, because if you read history and read about World War I and World War II, it makes sense that we still see ourselves as the defenders of the free world, and we need to spend all this money so that a China or a Russia or an Iran doesn't basically take over everything and screw it over for everyone. But I just wonder how much, 57% is so much more than any other country. If we just took 5% of that or 6% of that, then we would be able to give all of our citizens enough health care. And I feel like if we just really efficiently ran things in the military, if we didn't put so much money into tanks and ships just because someone's brother-in-law stands to make a lot of money by doing those deals, and if instead we were more like Russia and we focused on cyber security and space program and that kind of stuff, then we could still be just as good of a place in our defense, but have a much better position with our health, which, as you say, has all of these positive effects on our economy and our nation as well. Do you think we can ever get out of this rut?
Well, I don't know. I definitely, considering sort of the military expenditure definitely gets beyond my field of expertise. It certainly, I've heard it said that people, that basically the reason it makes sense to do that, and I'm not saying I agree with this at all, but is that, okay, we're not in wartime right now, but it would cost so much and be impossible to gear up in that time. But that's why we have to maintain this massive military industrial complex. But it does seem absolutely counterintuitive that we couldn't just divert those funds to the immediate problem here at home. And not only that, but the sort of immediately on the horizon one as well with the aging population. But then even just sort of thinking about the sort of economics of it intuitively, you think, okay, well, what percentage of people are covered by Medicare, Medicaid? And it's going to cost just X times that to cover everybody. Well, it's not actually true, because right now we are already covering the most expensive folks. So expanding it to the rest of the population wouldn't actually cost the intuitive multiple. So, for example, the healthcare expenditure per person over the age of 65 in the U.S. is about $19,000 a year. But the cost of healthcare per working individual is about $6,500 a year. So it's an increase that's about 3 times higher. So, if we're already covering those that cost 3 times as much, it's not going to cost the same per individual to cover everybody else.
Right.
And even in, again, sort of bringing back this idea of single payer, Medicare and Medicaid, although they don't actually cover a majority of the population, they're already covering the majority of the healthcare consuming population. So over 60% of hospital stays are actually paid for by Medicare and Medicaid. So they already have a majority in terms of the healthcare spend.
Yeah, and as far as how else we can decrease our spend, one trend that seems to be popping up everywhere is the trend of preventative medicine. Because in America, typically it's, you're going about your normal life of eating a dozen cheeseburgers and watching a dozen hours of Netflix per day and driving around in your car and sitting on your fat ass at work. And then one day you get a heart attack, and then you go to the doctor's office, and then they basically do all of these last ditch emergency efforts because you have lived so unhealthily up until that point that there's only so much they can really do. And that leads to very significant costs. Whereas if instead we took more of a method where, especially facilitated now by the fact that lots of people walk around with smart watches, there are now pills that you can swallow that basically will test your different blood levels, and there's another sensor that can measure your EKG, and there are all of these ways that we can monitor people's health in real time, but we have not yet at all, as far as I know, integrated that into any sort of broad healthcare plan. And also the idea that Apple has already started along this, but the idea that you don't just have everything that's relevant in your health records, like on your phone, in an app, that's able to be accessed by every doctor, no matter where you are. It's amazing that we haven't done that yet, and I don't know how long it'll take, but it seems like that's inevitable when we look forward into the future of healthcare.
And if not inevitable, definitely necessary. So certainly important to pursue. These sort of get to the heart of these sort of misaligned incentives that exist in healthcare. So another one of the massive considerations when thinking about the future of healthcare delivery is what does the reimbursement model look like? Not even just considering who's funding it, but traditionally healthcare in America has been entirely fee for service. You go to the doctor, they do a thing, you pay them for doing the thing. Well, that basically incentivizes more doing of things rather than more preventing of doing of things. Right? A doctor makes more money on a sick patient than a healthy patient is the unfortunate reality. So what incentive do we have to make healthy patients? The reality is that there aren't too many.
And I completely agree with that. The rebuttal that I hear from some of my friends who are doctors or parents or doctors is that, oh, but universal healthcare is going to be so rough on the doctors, and they spent all of this time and money getting their education, and now you're just going to basically slash their pay. So what would you say to that? Is there a way that we can, keep our because, there is a shortage of doctors in America. There's only about something like 2 doctors per 100 people or something like that, whereas in the UK and or in the OECD average, it's something like 3 doctors. So we are a bit low. How can we keep our doctors happy while also keeping our citizens healthy?
So I basically have 3 sort of thoughts or ways to approach that notion. The first is that there are ways to correct the incentives away from a fee for service structure, and actually has been introduced by CMS as part of the Accountable Care Act. These sort of accountable care organizations you may have heard of that basically share risk with the doctors. So right now, insurance companies hold all the risk and, of course, pay out for the patients, where a sort of increasingly common model is to form an accountable care organization, it's called, where the payer approaches a group or a network of doctors capable of meeting all the healthcare needs of a population of people. And they say, hey, look, doctors, we've got $10 million for this population of patients. We were going to pay fee for service, of course, but instead we're just going to give you this chunk of money. You guys care for the patients. And if you come in under budget, if you are able to keep them healthy to a certain level of standard for less than this money, that's yours as profit.
Wow.
If you go over, then that basically comes out of your pocket. So the providers go at risk with the payer. And so that aligns the incentives to pursue preventative health care. You see this also with much, much larger employers who have large group plans, such that it's not just that they're purchasing an insurance product from the company, but they're basically fronting their own cash and just hiring an insurance company to administer it. So this is almost certainly what the Bezos, Berkshire, Jamie Dimon consortium are going to be doing is taking their 400,000 employees, whatever it is, and basically understanding them as a risk pool and treating them as such and caring for them as such, rather than just having a big pool of cash which they pay fee for service. So that's kind of the first approach is correcting and aligning the incentives. The second is the sort of acknowledgement that, okay, yes, we have a shortage of physicians right now, but the degree to which there's a physician shortage is the degree to which is basically a function of how many patients a physician can reasonably take care of effectively. So we are seeing increases in physician extender type roles. So nurse right now, it used to be you saw the doctor. Now, mostly in the primary care world, you see a nurse practitioner a nurse practitioner who works under a physician, and that's increasingly common. So an increase in the number of nurse practitioners who are working under a physician as physician extenders. And I think technology has a huge opportunity. There's a huge opportunity for technology-based physician extension as well, such that a single physician can reasonably care for more patients and still provide the adequate level of care. But then also the other is that sort of the third way to analyze that is basically acknowledging that in the U.S. we largely overconsume healthcare. We've got this sort of odd dichotomous contradiction where a lot of people lack access to healthcare, but we also have over healthcare consumption. And that can be in the form of unnecessary procedures and unnecessary orderings, like that very, very wide range of C-section rates, for example, or things that are entirely preventable. So if we had a cultural shift that moved away from sitting on our asses eating, giving ourselves diabetes, then we could spend quite a bit less on that.
I mean, that sort of touches on what I was saying earlier about how great it would be if you could have an AI doctor guide to basically be your advocate through your healthcare decisions. So imagine Watson is already working on this, where basically Watson now they have just requested access to anonymized healthcare data for all of American citizens. So imagine if you have some ailment and your doctor recommends some prescription. Then you can just ask Watson in the same way that you would ask Siri, okay, what have been the results of people who have taken this medication with my ailment, maybe even with my genetic predispositions and everything specific to me. How have these people fared in the real world? And then you can decide what that is. Or you can see, okay, I have, these symptoms. What's the likelihood that I have a problem that would need to be addressed by an infectious disease specialist? And then with that information, you can decide whether it's worth it to actually pay to go see this specialist, rather than having it all be up to the doctors, which, like you said, with misaligned incentives, they get paid to do medical work. So people end up getting more medical work done than they actually need. It would be great to have some sort of guide.
Yeah, absolutely. The sort of, very, very, again, we're fairly slow to adopt good ideas in healthcare. So I'll say the near to medium term opportunity for precision medicine and the growth of that is absolutely a great thing for patients. So the available information for physicians to base their decisions. In the software and tech world, we've had Moore's law to the wind at our backs for a long time. But the number of transistors you can fit on any given chip doubles every 18 months. And that's sort of petering out, going parallel now. But in the biotech industry, a similar thing is happening with the cost of gene sequencing. So precision medicine and populate large amounts of data that's been essentially collected in these EHRs. We're able to analyze these now. We start folding that in and marrying that in with actually personalized recommendations based on understanding of your genome. Huge opportunity for precision and personalized healthcare without necessarily it being a massively, massively costly or burdensome thing.
Right. If we could sequence every citizen's genome and do some serious data science about what sort of diseases if we had everyone's healthcare records and everyone's genome sequenced and we just let an AI machine learning system have at it, we would have such incredible insights. And, people are definitely afraid of, what if someone hacks that data? It might be risky to have everyone's data available on some single server. And I think there's definitely a reason to worry about that, but I think we need to try to solve that either way.
Yeah, and I think in terms of considering that risk, because that's something that's highly relevant to our business, we of course face quite a bit of risk. We have to be HIPAA compliant and go to great lengths to be HIPAA compliant, secure, et cetera. The risk comes in two forms. There's the risk of actually exposing the patient's privacy, but broadly and culturally speaking, the risk that companies often consider is really just the teeth that exist by the ONC coming in and fining people. So that's a lot of times why people pursue cybersecurity. Is not actually for patient privacy, but more for just the penalties of not actually doing a good job of that.
What about
these are sort of.
What about the more sinister risks of, let's say, Russia creating a bioweapon after it hacks into the U.S. and finds out that 65% of Americans are susceptible to this one type of pathogen?
Well, so I don't actually think they would need any data to do that. We already have very effective bioweapons that
Right.
don't actually require a deep understanding of our own healthcare. So
Yeah.
I wouldn't actually see that as a risk too much personally.
Yeah.
But yeah.
Yeah, so it seems worthwhile. So then I just have one other question before we get into the worst case, best case, most likely scenario. So, one of the broad trends that we see is obviously automation, joblessness, income inequality increasing. How do you see all of that affecting healthcare? So let's say, in 5 years or 8 years where we have very high unemployment rate, and most people, the GDP of America is still great, but most people would not be able to afford paying for their own health care unless the government steps in. How do you think that's going to play out? Do you think like the people are going to rise up and basically in the next election or the one after that we'll get some sort of single payer in there? Are they going to have to increase corporate taxes? Like, are we going to need to get our spending in line? Like, what are we going to need to do, and how do you think it's going to play out given the trends of automation and joblessness?
Yeah, I think it highly depends on whether we know what's good for us or not. If we have an increasing income inequality and fewer folks who are able to access private health insurance via their employer, then we either need to say we're going to cover them some other way, or we have to accept that A, we're just okay with them not receiving coverage, which I think is unlikely, or B, accept sort of tolerating that they're going to accept or access the absolutely most expensive coverage. So, for example, the Affordable Care Act greatly expanded Medicaid, but arguably didn't go far enough. So when they created the insurance exchanges, they basically, in order to appeal to moderates, okay, people can list insurance products in the exchange. There was going to be a public option that people could choose, but it was cut. It was cut from the bill before it was passed, basically to appeal to moderates. And had they provided a public option, perhaps folks who otherwise wouldn't have an option would have greater options. Again, it seems strange that people who are opposed to the Affordable Care Act would choose to decrease the amount of competition. But I think basically Medicaid will need to be expanded if we are to be able, if the income inequality is going to continue to grow and the access to private coverage is going to increase. Otherwise, you have folks going to the ER for things that can be treated for much lower dollar. So that's, I think, basically a necessity and probably an inevitable one on a step towards a largely single-payer system.
Yeah. Awesome. Well, I think we are making some good progress in that department, seeing where things are going politically. All the people who support national health care seem to have just won in the midterms, whereas all people who opposed national health care seem to, not win. So now I want to talk about the worst case scenario for the future of healthcare, and then we'll get into the best case scenario. So given the direction of where things are heading, what's the worst realistic scenario of what the future of healthcare could look like in America in, say, 10 years?
So I think the possibly realistic worst case is that the incentives basically collapse. So if we perhaps go too aggressively towards a system that physicians don't accept and say, oh, our wages are going down, this kind of thing, and there isn't enough incentive to become physicians, and either we don't get to a place where people have access to the healthcare they need, or we get to a place where they, in theory, do, but there's no one to actually treat them. And so that's I think a realistic sort of worst case scenario that there's sort of organic collapse. So I think it'll be a delicate transition, but yeah.
What's your answer, Justin? I think Justin is frozen at the moment, so I'll give my answer. So I pretty much agree with you. I think that if we continue along the lines of the healthcare pharma complex, similar to the military-industrial complex, where we continue to have, like you say, misaligned incentives, and if you combine that with income inequality and with people who are out of a job, can't pay for their healthcare, the worst case scenario to me is basically if politically there's a gridlock for whatever reason, so we're not able to pass some form of expanding of the Affordable Care Act or some form of national health care, and then we continue along these lines of misaligned incentives, then most people will not be able to pay for their own health care and will live in a world that is highly unequal, where the people who have a lot of money can pay for great healthcare, and America continues to innovate because we have been innovators in healthcare technology, even though oftentimes those gains are just copied by the rest of the world. And I think that's just a world where it's a lot shittier for most people, but for some people, it's fine. And so that's the worst case scenario as I see it. But obviously, it can get much better. So for the best case scenario, for me, it's something similar to the way that airplanes run right now, where for most of the airplane flight, the autopilot does everything. The only part that you need the manual actual pilot to do something is taxiing, some tough landing takeoff situations. I imagine that as being the best case scenario for the future of healthcare. And the way that we would get there is, so one thing I've heard suggested is, if we have something a like a president's plan where, let's say the president of the White House can basically highlight all of the startups that are doing the best job in healthcare, and then give them access to public funds and sort of help these companies that are already doing a very innovative job, helping them to grow and to provide a greater amount of services. So let's say like the US identifies the top telemed companies, and they do a study of which ones are the most effective, which ones give the greatest possible reach to the greatest number of people, which ones give the greatest quality, all of these different indicators, and then basically allowing that to flourish and to grow so that people can have access through their phone, through their app, to anytime they need to talk to a doctor, they can talk to one. Anytime they need to make an appointment, they can make an appointment. Anytime they need to get meds, they can get meds. And then we still would have the manual human doctors if you need to actually get a surgery. But by preventing better preventative medicine and by tracking what's going on in your body throughout your daily life, and if even we combine additional things like having some sort of a scanner, like an at-home scanner, so if you ever need to get an MRI or anything like that, you can also get that done. If we combine that with our experienced doctors, then it could be more efficient, more cost effective, and it would be something that the government would be able to pay for entirely. And if we pay for it entirely, then I think our whole nation will flourish. And it's another question of what that means 100 years down the line, because I think at that point our lifespan will be so much greater that the costs will be a lot higher. I mean, what does the universal part and healthcare part, what do each of those words actually mean? Like, does everyone get it, and for how long? Like, what if people end up living to be 500 years old? How do we pay for that? So I'm only talking about the best case for like the next 10 years. But yeah, anyways, that's my 10-year best case scenario. It gets a little trickier as you go out further.
Yeah, I agree. I think best case for me is that we see orders of magnitude increases in the efficiency of the delivery of healthcare and the access to healthcare, that it becomes more like shopping from Amazon than going to the DMV, if it could go in either direction. And then also we see orders of magnitude increases in the ability to adopt innovations and improvements in the sort of art, science, and practice of medicine across the healthcare system. So the better we can mobilize those and give access to those, it will, of course, be better for everybody as a whole. That's what I'm hopeful for.
Can you guys hear me now?
Yeah, we can hear you. So what's your worst case, best case, Justin?
So I would echo a lot of what you guys said for the worst case. It sort of, we'll get to the most likely, but I think the worst case is actually closer to the likely case, at least in the US, because I think people are probably more likely to stick with the status quo, but hopefully, we have all of these awesome startups coming along. We just need to make sure that policy makers can actually adjust with the technological changes, because they're ultimately the gatekeepers. So anyways, for the best case, so similar to what we were talking about earlier, healthcare quality can improve with technology. And one of the people that I really follow in this space is someone called Peter Attia. He's a physician. I think he's actually in your neck of the woods, John. I think he's in San Diego and New York. But he talks about how with more precision measuring in so in healthcare, if we can measure things more accurately and at a more precise level, we can detect things like cancers, heart disease, hypertension at way earlier stages than we can even conceive of right now. And we can have sort of this technology in our pocket that is always with us and we can really take advantage of these advances where, a doctor's ability is scaled to almost unbelievable levels. And then the other part of the best case is very similar to what you were saying. I love what you were saying because I'd never actually thought about that earlier. I've never thought about the actual solution or how it might actually be implemented. So that's a huge part of the best case scenario. And then the last thing is, with all of these new technologies, let's say we have some sort of sensor in our body. Maybe this is definitely beyond the 10-year period, but we have something in our body that can basically read our blood levels in real time. Because right now, our readings come, at most, for wealthy people that really care about their health, once a quarter. They're getting blood markers read every quarter, let's say. Now, your blood levels change drastically throughout the day, whatever you're measuring, especially something like glucose. But if you can have more precise and more real-time data on yourself, then you can truly figure out what the best healthcare and what the best lifestyle is for you. And we can truly optimize preventive medicine, and we can expand our health span. So a lot of people talk about lifespan, how long are we living? But what I think matters is our health span. So if let's say we live to 150 years, but we're only healthy for 80 of those years, and the rest of 70 extra years we're alive, but kind of in the state where we're sick all the time. I don't know if that's any better than just living to 80 and being sick for 10 years, or being sick for 0 years. If your health span is 80 and your lifespan is 80, that seems almost optimal rather than expanding lifespan all the way, to 150 if you're not going to be healthy for a lot of this.
Do you guys think
Sorry,
that? I was just gonna say it made me think of something where, so like imagine if we get these push notifications, basically. So, oh, your levels are a little bit off today. We recommend that you take this test at home or see this doctor. Imagine if you're getting those. Something I just thought of is, do you think that's going to turn us into people who are much more relaxed because we have this safety net that's basically monitoring us, or is it going to turn us into techno hypochondriacs where we're always like freaking out about if we're getting sick? Because I could see it going either way. Maybe it just comes down to what type of personality you have.
Yeah, I think best case it coincides with sort of cultural shift where we care about our healthcare more, but do so in a way that actually isn't misguided and misdirected, so that we're not doing things that we feel are good for our healthcare, but things that actually are good for our healthcare. And I think those are the sort of cultural shift of people caring about their healthcare is going to be a necessary component of sort of some broad improvement in the healthcare system.
Yeah, like you have a big night of binge drinking with your friends, and then you get some like alerts on your phone, like your liver levels are critical, and or you like go have like a really like fatty meal, and you're like, oh my God, I've got so much salt in my blood right now, and that might be good. Because right now it's kind of just like behind this veil of you're like, oh, I really shouldn't have done that, but you don't really know how bad it actually was, and so I think it will overall be good, but for some people it might make people more hypochondriacs. But anyways, John, what's your most likely scenario?
Most likely, actually, I'm gonna err on the side of optimism in this case. I'm gonna say most likely that we continue to see broad improvements in the quality of care, but that care does become more accessible, and that folks do make attempts. So certain things that do give me hope are the Bezos Consortium, right? They're going to go after very low-hanging fruit. Atul Gawande has been appointed as the head of that, and he's a very smart guy who has very good ideas about population health. Kaiser Permanente in California, they're doing some very interesting things as well. Actually, so they basically have a very, very large healthcare system that also acts as a payer, and they are also opening a medical school. Just massively interesting. So they're sort of going full stack in terms of the healthcare delivery. So both of those things give me a good amount of hope in terms of the direction that we're going.
Do we have any sense of when Amazon's healthcare solution would be available? Because I know right now they're pretty much just focusing on making it up and running for all of their employees. We have any idea when they might be able to provide that? Yeah, it's because that does give me a lot of hope. I mean, the way that they've been able to manage the logistics of essentially America's entire brick and mortar economy through Amazon is pretty impressive. So if we could do something similar with healthcare, that would be great. For my most likely scenario, I think that in the next election, the next presidential election, whether it's Democrat or Republican, I think in either case, they are going to put a healthcare bill and pass a healthcare bill, and that it will expand healthcare or maybe replace it or maybe improve it or whatever. It's going to in some way enhance what we have already. The question is how much of an enhancement that is. I think when we talk about most likely, with any sort of major bill, there's going to be lots of earmarks and there's going to be lots of things that we would wish weren't on the bill because they're going to get extra profits. And so I don't think it's going to be like, I think it's too rosy-eyed to think of this as like, oh yeah, in 4 years or 8 years, we're going to have great universal health care. But I think I agree with your optimism, and I think it will be marginally better. And I think there's also going to be another wave of progress once the automation and joblessness reaches a critical point. And at that point, people are going to simply demand that we have better access to healthcare. And maybe that critical point coincides with Amazon finally being ready or some other player having a much better solution. And at that point, we can sort of go into phase 2 of like a digital healthcare system that really works for people, where they can get what they need, they know what they're paying for. So I think that's, that would be my most likely scenario.
And just to add to what I was saying earlier, with it seemed a little pessimistic. So when I was talking about the likely case, I was talking a little bit more about this election cycle and maybe the next, depending on if somebody gets reelected. But after that, there will be a time where we see more technologically savvy and more, just a different philosophy get into the political realm and passing bills. So longer term, let's say 10 years plus, I think that we're going to truly there's nothing we can do. We can't ignore the technology anymore. And that's when I think we'll see these awesome advancements.
I agree. So do you have any final thoughts, anyone, on any advice for people who are deciding how to deal with their healthcare, or maybe people who are stakeholders in the healthcare system, how they can help bring these trends to the front, or any other final thoughts for our listeners?
I think if I had one final thought, it's that as we think about all this in terms of sort of a systems approach, I think it's important not to lose the perspective that fundamentally healthcare is sort of the core of the human experience, and that we need to make sure not to lose the humanity that exists in healthcare, or to overlook that.
Yeah, I'm with you. Well, thank you everyone for listening. This has been the future of healthcare.
We're going to talk about what has happened, what is currently happening, and what will inevitably happen.
The past, the present,